welcome you all to our webinar today, which is amongst our Business Reconfigured series of webinars we are launching in the upcoming period, including economic implications during COVID-19 on the 5th of May and healthcare quality initiatives on the 7th of May. You can join by registering through the Executive Education Facebook page or the Executive Education website. Today's webinar session will be on hospital management challenges during COVID-19, featured by Dr. Khaled Noury. Dr. Khaled Noury is a dedicated medical doctor with extensive practical experience and academic knowledge in healthcare management. He occupied top managerial positions in different healthcare settings as former chairman of General Authority for Healthcare Provision, Universal Health Insurance Ministry of Health, CEO and CQE of Cleopatra Hospital Group, COO of Children Cancer Hospital. Before we begin our webinar session today, I'd like to first share some engagement tips that would help enhance this webinar experience. Please keep your microphones muted so we do not experience any noise distortions. Please do not open your camera or start a video so we maintain a smooth streamlining connection. We have ample time at the end of the session to answer all your questions, so please park all your questions till after the session so they are structured comprehensively and in relation to the entire discussion. During the question session, if you have any questions, please write it in the chat box. And if you would like to ask your question privately, please send it on the chat box addressing Heba Muntasir. We want to stick to the hour designated to this webinar and wrap up at 3 p.m. today. We hope you all enjoy today's webinar. Thank you all. Dr. Khaled, the floor is all yours.
Hello, good afternoon. I hope everyone is enjoying his lockdown now. Everything will restore to normal soon, inshallah. As Dr. Heba said, I am Khaled Noury, former chairman of the Healthcare Provision Authority. This is one of the three authorities of the National Health Insurance System. Our webinar today is talking about the hospital preparedness in facing COVID-19. The WHO have issued a document late February about the hospital preparedness plan during COVID-19. We will go through some items or some elements of this document. Also, our presentation have referred to the CDC guidelines to get an objective information about this issue. So the title is Hospital Management Challenges During COVID-19. Our topics we will talk about in this session: the incident management plan, surge capacity and capability, facility management, laboratory and radiological preparedness. We will start with the incident management. To start with, what is an incident? An incident is an event that could lead to loss or disruption of the hospital operation, services, or functions. And this incident, if not managed properly, can escalate to an emergency or crisis or disaster. So this is the incident. The incident management is a term describing the activities of the organization of the hospital to identify and select to identify and analyze corrective hazards and prevent future recurrence. And the system is a combination of personnel, equipment, procedures, and communication that work together in emergency to react, respond, and understand the incident itself. In any accreditation program, whether it is GCI or Gahar al-Masriya, or Sibahi al-Saudiya, even the Canadian and the Australian, the incident management system is covered in the disaster plan and crisis management chapter. If the hospital has an emergency response plan, then immediately activate it once the incident happens. If not, establish an ad hoc incident management team. This is a supervisory body responsible for directing the hospital during an emergency operation. This team should have a center or location to convene and coordinate the hospital-wide emergency response activities. This center should be equipped with well-functioning means of communication. Also, we should have a commander or lead for this team. The lead persons from each department should be assigned. And also we have to take in consideration that we have to get replacement just in case if these key persons are not available for any reason. So this is the structure of the incident management team, the incident commander. The incident commander, not necessarily to be a chief person or senior person. He should be a knowledgeable person about the hospital operation. He should have a good communication skills, and he should be empowered by the hospital management team so he can take decisions without permission from higher authority. So he has a final say on the incident management. Will help him as a public information officer for the communication with the community and the healthcare authorities and the people around in the hospital. Also, the safety officer is a key person. Then we have the medical staff or medical head of departments or nursing head of departments. Then in the lower box, we are talking about the support services, which are the operations, the facility chief, the logistic and supply chief, and the financial administration chief. So those are the members of the incident management, and they have the authority to take decisions and to handle any problems that face the hospital during the event. So what are the activities or goals that the incident management team have to do? They have all 5 functions. I mean, number 1, prevention. Prevention, so they are doing this and it happens about they do their homework as regards the risk assessment, the risk analysis, the resources required in the hospital. All these issues are very important to prevent the incident from happening. Once the incident happens, then they take measures to protect the staff and patients and resources. Also, they have a role in mitigation. Mitigation is to minimize the impact of the incident on the individuals and on the facility. Also, they have to respond to take immediate action to restore activity back to normal operation. And finally, the recovery, which is take corrective action to prevent the incident from happening again. To do this, actually, they have 6 steps. So again, as we mentioned before, that before the incident, there should be a top management commitment and leadership support for all the staff in the hospital. The hospital should have what is called safe and just culture. Safe, provide patient safety, building safety, risk-free from any hazards. And this should be a documented plan. Also, we are talking about just culture. So in the just culture, we are not aiming to pinpoint who is responsible for the incident. 95% of the problems come from the system errors, not from the individual mistakes. So 95% are system errors. It happens in front of one person, so we can pinpoint for him that he is responsible for this. Actually, this is not the case, and this is not true. So we have to get the just culture, and this just culture is giving comfort for everyone to be transparent and to identify what is the wrong thing and what is the right thing. So once this is before the incident happened. Once the incident happens, there is an immediate response activity. We care for the patient. We care for the staff who are subjected to the incident. We care for the visitors, we care for the vendors, we care for any one of the stakeholders of the hospital, that because they are actually they are representing the entire environment of the hospital, and without them we cannot operate properly. So we have to care for them and provide the necessary support during the incident. Second step is to report the incident according to the hierarchy and according to the level of the incident, because once we have the incident start from near miss, that incident does not happen but discovered before it happens, to the incident that happens like without having an effect, then it turns to an accident, and the accident is that has an effect or side effects on the individuals or the place, and finally a sentinel event that results in loss of life or similar to this. So these are the grades of the events or incidents that happen in any hospital. Also, one of the important things once that incident happened is disclosure. We have to announce that we are knowing that we have an incident, and we declare our responsibility for this, and we declare what activities or what actions we have taken to alleviate this. Then we move to the prepare for analysis. Prepare for analysis, we are doing preliminary investigation and select an analysis method. The analysis method here could be, for example, if we are looking for a root cause analysis, we can get the fishbone diagram. This fishbone diagram can help us to identify the hidden areas that we cannot see immediately. Once we have the incident, it gives us a scope of probabilities or a scope of reasons that could lead to this incident. And we coordinate the meetings with people who are involved in the incident and plan for and conduct interviews. The analysis process itself, we are investigating what happened, understand how and why it happened, and develop and manage recommended actions. So this is after the analysis process finish, we go to the follow through. We are implementing the recommended actions, and we monitor. So we are talking about what kind of incidents hospital could face, especially during the COVID-19. Many things could happen. We will talk about 4 or 5 items. For example, what if a patient received medication and he got adverse effects? This could be an incident. The shortage of the personal protective equipment. What should we do? I mean, the supply manager, what he will do here, the supply manager should have been preparing for this before and provide ample supply of these disposables or these equipments. And just in case, if it is, for example, if there is a shortage in the emergency room, he can double check with other departments. If they have surplus, they can provide this to the emergency room. Actually, he can communicate with the supplier to provide him immediately with other amount of these equipments. Or he can advise the facility manager to reuse some of the washable gowns that the hospital may have. Another example in COVID-19, what if an incident happened that the ER department received a rush of cases at the same time? Are we prepared for receiving them? Did we have a plan for receiving them from the beginning or not? Do we have the number of staff that can provide the services for 20 or 30 patients at a time? Then we will talk about this in details in the surge capacity. What if an employee became sick and it was discovered that he is COVID-19? Actually, the HR manager should be notified about this and check with him if he has contracted COVID-19 or not. If he has contracted COVID-19, then he should report to the security manager so he can trace through the control and video surveillance cameras the interactions of this person with others. I mean, there is a lot of things could be done with the security people as regards the tracing. And the last example, what if the power failure happens in the operating theater? This is a major incident and it could jeopardize the life of the patients inside the operating room. So do we have a backup generator? Do we have a battery for the operating room or not? And what would happen if we don't have this in the same immediate time? Are we ready to with an electric lantern? So, I mean, we have to be prepared for all the possibilities and incidents that happens. Our second subject today is the surge capacity. When we are talking about surge capacity, we are talking about the ability to care for a markedly increased number of patients beyond the normal capacity, operational capacity of the hospital. And here we are focusing, as regards the surge capacity, we are focusing on the numbers of hospital beds, numbers of personnel, numbers of pharmaceutical drugs, numbers of supplies and equipment. We have to differentiate between surge capacity and surge capability. In the surge capacity, as we mentioned, we are focusing on the numbers. On the surge capability, we are focusing on the quality or not the quantity. We are talking about specialized medical care that is not available at the hospital. So we have to get also, in this, we are talking about, we are focusing on, in the capability, we are focusing on the expertise, on the information, on the procedure, on the special equipment, and on highly specialized personnel not normally available at the location. There is 3 stages in capacity planning model. I mean, number 1, assess the current state. Number 2, determine the strategies and activities. Number 3, develop plans. And each of them have 3 sub-steps. I mean, in the assess current state, we are talking about, do we know the organizational roles and responsibilities? Are we assessing the resources? Are we assessing the performance? So this is the state of assessment. Develop the strategies and the plans. And once we develop the plans, we develop how to maintain it and sustain these plans on the long term and how to evaluate them. This is very important in developing the surge capacity. And in this diagram, we can see, I mean, what we will focus on: staff, supplies, standard of care, ICU expansions, and resources. So, I mean, if we are talking about the space, I mean, really there is, doesn't happen all the time in the same magnitude. I mean, sometimes there is a conventional activity, sometimes there is a contingency, and sometimes there's a crisis. So as regards the space, I mean, usually, I mean, do we have, for example, if we would like to expand to receive more patients, do we have, for example, closed wards that we can reopen? Do we have, we can use the outpatient clinic as a triage area. We can use the recovery unit as a triage area. Also, we can use external building belonging to the hospital and change it into, transform it into an area that can receive patients. They don't, I mean, at least as a triage area. I mean, if we, just in case we have a lot of patients coming, then the hospital should have been thinking about, thought about having some sort of external triage area, for example, a medical tents, or I mean the hospital, field hospitals The military usually builds these field hospitals in areas without good infrastructure, so they can provide a lot of patient services within this military or field hospitals. Just in case, we can go through other community buildings like schools or courts or whatever. I mean, we can use them as a satellite services for the hospital. Second item is the staff. When we are talking about the staff, how can we increase the numbers of the patients of the staff during the pandemic of COVID-19? We can actually recruit part-timers. You should have a list of these part-timers available with us. We can recall the retired people, retired staff, retired doctors, retired nurses from the retirement and ask them to provide the services, and definitely they will be, recompensated for this. Also, we can utilize medical and nursing students, and also the non-medical volunteers that can work in other areas not related to the clinical services, in the support, in the communication, in the security. I mean, we can utilize volunteers' activity in Egypt in doing this function. Then we come to the supplies. We have to ensure that the supplies are available, and if in case there is a shortage of them, of some of the disposable items, we can reuse them after authorization from the infection control guidelines and re-sterilize them. Usually this is not acceptable in the routine practice, but in the short time, in the shortage period, we can go for this at least under control, the infection control guidelines. And as we mentioned before, we can use the washable gowns in use it and wash it, use it and wash it, use it and wash it. This will provide an ample supply of the personal protective equipment. Finally, we can talk about the healthcare. From the functional point of view, what can we do to receive a lot of patients, during the pandemic or the incident itself? Actually, we can classify this into three categories. Before coming to the hospital, we can create a medical call centers. These medical call centers are run by specialized staff, doctors or nurses, and they can answer questions from the patients coming on the telephone line, whether should he come to the hospital or not, and discuss with him, the necessity of being in the hospital. If he must come, then they will advise him to come. But they can remove a lot of burden from patients who have worries only, and instead of coming of the can utilize the call center. Also, the telemedicine. There is a telemedicine approach. Doctors who can discuss in details their cases and use some of the modalities like the PACS system to see if they need actually to come to the hospital or not. Once they come to the hospital, to the triage is an important area, and we should keep in mind that this area is actually an area where we decide whether the patient needs an immediate care or he can be delayed or postponed or come another occasion. So, usually the triage area is the entry gate of the hospital, and it should have an adequate staff with personal protective equipment, and this area should be properly ventilated, and it's advisable to examine these patients in a separate cubicles, and we can expand the emergency or the triage area to inside the hospital areas like the post-anesthesia care unit, pre-induction unit, or some of the procedure rooms. Once the patient is decided to go to the inpatient, then we have to get them to have plenty of places for the coming patients. We can do this by, minimizing the burden of the inpatient by discharging patients as appropriate. I mean, if the patient is in a good condition and does not need to stand more in the hospital, then he can be discharged. Actually, you can postpone the elective cases. I mean, in the COVID time, we don't have to make a surgery like cholecystectomy for an obese patient. I mean, this kind of surgery can be postponed into a later stage unless there is a complication or there is a life-threatening factors. Then this will be an emergency case and we will deal with them. But one of the key concepts is to postpone the elective cases. And of course, to provide extra beds. So by this, we can say that we have covered the surge capacity and capability. Now we will move to the facility management concerns. And in the facility management, we are talking about housekeeping, support, security, electromechanical maintenance, and many other things that are within this scope. So actually, we can talk about first the housekeeping. Housekeeping is, play a crucial role in managing and controlling the infection in the hospital. So they should be trained staff. They should be wearing their personal protective equipment. They should follow the standard operating procedures of cleaning the rooms from inside out and using the disinfectant approved by the hospital infection control group on the surfaces and in the toilets. And I mean, they have a lot of, there's kind of service level agreement will be followed between the housekeeping staff and the hospital. One important issue about, what if a patient comes, enters the hospital, enters a room, and that this patient was discovered to have a COVID-19? Should this room be used again, or how can we handle this subject? Actually, it depends on many factors. I mean, if we have a patient with COVID inside a room, for example, inside the inpatient or inside the outpatient or inside the triage room, we have to look for some items. For example, the size of the room, the number of air exchange per hour in this room, how long the patient was in the room, if the patient was coughing or sneezing, if he performed an aerosol generating procedure, then this issue will determine how long the room should be kept empty before allowing other persons or other patients to come into the hospital. One of the things that I'd like to talk about is what is called the aerosol generating procedure. These are procedures that will enhance the expulsion of droplet particles from the patient who have a disease. For example, we are talking about sputum induction. We are talking about use of nebulizers, procedure like bronchoscopy, cardiopulmonary resuscitation, endotracheal intubation, non-invasive ventilation like CPAP and BPAP. All this element actually will increase the particles in the room, and this will leave, we advise that the room should be closed at least 2 hours before allowing the patient to, other patient to come into this room. A third element of the facility management is the indoor air quality. The indoor air quality, this is a very important factor that some hospitals is ignoring this element, but it is very important in handling infectious diseases and in good care. Usually, the recirculation of the air should be prohibited in the patient rooms with COVID-19 unless there is a use of HEPA filters. HEPA filters, these are high efficiency particulate air filters that prevent the entry of microorganisms from 0.3 micron and upward. This could be of, so recirculation in the room is not allowed in the infectious diseases. Also, the air exchange rate, it should be 12 air exchange rate per hour, per room. And it's preferred that the exhaust fan of the hospital, of the patient room will be above the head of the patient. Also, these rooms must be negative pressure and negative to the adjacent corridors. And there should be a local visual indicator of the pressure is available at the hospital, at these rooms to show to the inspectors that everything is going right. Also, as regards the indoor air quality, we are talking about humidification. It is proved that humidification with a range from 40 to 60% humidification will get rid of 90% of the viruses. And we are advising the hospital humidification to be between 40 and 60%. We don't want to increase it above that, although this will kill more of the viruses, but actually it will encourage kind of mold growth in the patient cells, in the patient, especially those who are immunocompromised. The final tool we are using in the indoor air quality is the ultraviolet. The ultraviolet is germicidal and it can be safely installed in the mechanical ventilation pathways or in the room of the patients. So we can use this as one of the tools that we are fighting the virus in the rooms. Other support services, I mean, we can talk about how we are dealing with the food. Are we anticipating the good supply for the food during the COVID-19? We have to take a proactive measures to ensure the availability of the food, also to ensure the food safety. I mean, we cannot ignore this factor as it is one of the roots that could lead to, I mean, another epidemic in the hospital if we don't care about it. Other support service, we are talking about the utilities to ensure that we have continuous water supply. If we have the water tanks for should be secured. The power, the electricity, any hospital should have a double grid supply from two sources from the main electric station. Also, they should have generators that cover the critical areas. And we have to, as a hospital management, should ensure that these generators are well maintained and working on proper way. Also, we can use the battery for the critical areas. I mean, for example, there should be a backup battery for the operating theaters and the intensive care units. Last thing in the utilities, we are talking about oxygen supply. The oxygen supply usually should be secured and backed up by another battery of cylinders with the equivalent amount of the original cylinder to just in case if there is a delay of the vendor to supply the cylinders to the hospitals. It's preferred that the hospital should have its own oxygen tank. The oxygen tank usually can be filled or refilled on a distant spaces of timing, so it will secure the oxygen supply for a good time. Last thing about the oxygen, I mean, some hospitals now are doing what is called oxygen generator. These oxygen generators are generating oxygen from the surrounding air. And this has been used in a lot of hospitals now. I think now Egypt have almost 30 or 35 hospitals that are using this oxygen generator in the, as a routine for the oxygen supply. The security. I mean, we have to talk about the security. I mean, security play an important role in controlling the environment of the hospital. They should have limited access to the hospital, limited number of people, and limit the visits. Also, they should guard against any attempt of breaching the hospital for any reason. They should control also the traffic and parking in the hospital so that they can facilitate the movement in and around the hospital. Last thing we are talking about in the facility are the morgue. And we have to, just in case if we have a mortalities, then large number of mortalities, we should be prepared by having the body bags and the coffins and the appropriate partners, the undertakers and the funeral services. By this, I should have covered the facility management issues that concerns the COVID-19. We will talk about the laboratory services and the radiological services. As regards the laboratory, we are, any laboratory should ensure the availability of its basic laboratory testing. For example, the hematological test, complete blood picture, biochemistry profile, electrolytes, blood gas analysis, blood culture, sputum examination and culture. All these are basic requirements for the COVID-19. And definitely, I mean, the diagnostic of polymerase chains reaction, I mean, it should be available. So we could do an IgM that indicates there is a recent infection, or IgG that you have an immunity for the COVID-19. The kits and solutions and aerosols should be available and maintained all the time. Also, the laboratory personnel and we should have a backup all the time, because sometimes if one of them is sick or have caught the virus, then we should have a replacement for him. We should arrange for an external laboratory service, lab-to-lab services. And one of the things on proper labeling on the samples and proper transfer and packaging for these samples. Last thing in the lab, we have to focus on to ensure that there's a prompt transfer of the results to the healthcare practitioners and to the healthcare authorities. This is very important in handling some cases. Finally, I mean, as regards the radiological services, again, the most commonly used radiological test is a chest X-ray. We should have a portable chest X-ray equipment in the emergency room. This will be enough to diagnose the cases with virus finding. As regards the CT, actually the CT is not present in all the healthcare facilities. It is now present in a good number of hospitals, but if it is there, actually it could be considered the modality of choice to diagnose because of its high sensitivity in dealing with in discovering the effect of the virus on the patient's lung. So, I mean, in COVID pandemics, we should take the lead in our hospital to close the gap between our current capacity and capabilities and the expected challenges. And I would like to close by quoting from Benjamin Franklin. By failing to prepare, you are preparing to fail. I hope that I've got a good presentation for you about the hospital preparedness for the COVID-19.
Thank you, Dr. Khaled. Now it's time to answer your questions, and to receive it, you can write it down in the chat box. Now we have a question, Dr. Khaled. Will PCR for COVID-19 be available in most private hospitals soon?
Actually, up till now, it is not available in most of the hospitals. It is a matter of the pandemic or epidemic control in Egypt. The Ministry of Health is restricting doing this to have the overall sight of the cases that are having the disease. So they are limiting it to the 29 location all over Egypt. Previously, it was in the central lab in Ministry of Health, which was one at the beginning of the pandemic. Currently, I think there is a 25 governorate central labs are doing this for the patients.
Okay. Another question, should we ask all health institutions, even the private, to offer an isolation area in case of any patient admitted with a chest manifestations?
Actually, we have to ask them this all the time, not necessarily only during the pandemic. I mean, every hospital should have an isolation room and to put the patient in it if they have an infectious disease.
Dr. Khaled,
Yes?
can you hear me? Yes. Okay. Another question.
Yes?
I need to know the role of risk management with the pandemic COVID-19 in hospitals.
Actually, it will need another 2 webinars to explain this. So let's answer this on the
Yes.
personally. Not, I mean, we'll go through. I mean, actually, it is a matter of risk management, and the risk management for the hospitals are wide scope, and we can go through it in private talk.
Yes, if I can add, Dr. Khaled, we will tackle this topic in the next webinar next Thursday with Dr.
Thanks.
Muhammad Khalaf Anwar. Yes.
Okay, all right.
Yeah. Okay. What is the best material that could be used for disinfection in disinfected gates? And the same doctor is asking as well, what about the machines used in surface disinfection for hospital rooms?
Again, please, the question. Again, the question, please.
What is the best material that can be used for disinfection in disinfected gates? And she's asking again, what about the machines used in surface disinfection for hospital rooms?
I mean, when we are talking about the surfaces, we are talking about, I mean, the office surfaces and tables. And we are not talking about the lands or the floor, right? I think this is, I mean, I think that there are a lot of materials that can be used in this. I mean, again, we are talking about the alcohol, and the alcohol is primarily used for the hand rub. But also the materials of the, the Clorox. The Clorox is again is a good material that can be used all over the surfaces, and there is a lot of materials that companies that are providing this. I don't have the list now, but I can share it with you at a later stage.
Okay. Concerning the question with the isolation rooms, one of the doctors is mentioned, and if we don't have an isolation room at our hospital, what shall we do?
Actually, you can create an isolation room with a simple procedures. I mean, it's a matter of that you are increasing. I mean, you are increasing the air into the room, the airflow into the room by making this. So, I mean, you are if you have a fan that introduces the air into the room and the exhaust fan, you can control this process by increasing the airflow into the room and decreasing the exhaust fan. Again, I mean, any hospital should have an isolation room with a HVAC system, with a ventilation system. All right, we are talking about hospitals that are not prepared, and probably, I mean, if these hospitals are trying to get a license now, they will not be allowed to have a license without having a negative pressure room. But again, we can create this by some sort of electromechanical handling within the room itself.
Okay. Another question, this preparedness plan needs a lot of training to all engaged staff. While all staff are busy and under a lot of pressure, how far are we from completing this needed training?
From what?
How far are we from completing this needed training? Do you want me to repeat the question, Doctor?
No, no, okay. I mean, as I said before, I mean, in the previous in this presentation, that we have to be prepared from the beginning. But what I mean, the question say, what if we were not prepared? Actually, we can prepare ourselves, whatever time it will take. If we go through this process and gradually, we will at a point will be better than before. Not necessarily we will be perfect, but we will be better than before if we start training from today. Yes, we are in the middle of the pandemic, but we can start training from today, and tomorrow we will be better. Not necessarily we will not be perfect, but we will be better.
A question, is full PPE, personal protective equipment, going to be obligatory to all healthcare providers, even non-medical personnel in all hospitals?
I am doing this at my hospital, yes. It should be obligatory. At least the mask and the gloves. But when we are talking about the gowns, we can say that we can leave the gowns for the people who are performing procedures with the patients.
How can we calculate expected PPE?
By calculating the number of people who are doing the procedures. I mean, it's again, for each person, we have to give him, each person will go through the person with the contact with the patients should wear a personal protective equipment. So we can calculate the number of these patients, of this staff, and multiply it by 2.5, because 2.5, this will give us the rate of exchange and the number of patients exposed to the procedures.
What can we do for a patient who totally refuses taking the swab and asked for discharge upon request?
Actually, we will try with him, I mean, again, and tell him that this is, I mean, for his sake. And we, if we fail to do this, we have to report this case to the healthcare authority responsible for this community.
Okay. Any more questions? So far, Dr. Khaled, we covered all the questions. Thank you for the attendees. Thank you, Dr. Khaled, and waiting for you to join our upcoming webinars, including the healthcare topics and other topics. You can find it all on the Facebook page and the website of the Executive Education of the American University in Egypt. Thank you so much.
Thank you.